Investing in world peace development is about ensuring that our children and our children's children inherit a world that values collaboration, mutual respect, and peace. It's about creating a legacy of peace, a world where violence is not the norm, but the exception. Because ultimately, that's the greatest gift we can give to future generations. Look, I know we've been talking about some pretty big, complex ideas here, but at its core, peace is actually a very simple concept. It's about kindness, it's about empathy, it's about recognizing the inherent dignity and worth of every single human being. These are values that are echoed in spiritual and philosophical traditions all over the world. And embracing these values, putting them into practice in our daily lives, is essential for cultivating a culture of peace. A world where everyone feels valued, respected, and loved.
Health is not a privilege. It is a fundamental human right that every individual deserves. This core principle underpins the global movement towards ensuring everyone has access to the care they need. Yet, for billions across the globe, access to essential healthcare services remains a daily struggle, often due to financial barriers or geographical limitations. This disparity highlights a critical global challenge. Today, we will embark on an exploration of how various countries are actively building and refining systems designed to make comprehensive healthcare accessible to every single one of their citizens. We will delve into the diverse approaches and models they employ. Universal healthcare fundamentally means that every person, regardless of their socioeconomic status or background, has guaranteed access to the health services they need, without the burden of suffering financial hardship. It ensures that medical care is a right, not a luxury. This vital concept is robustly built upon three interconnected and equally crucial pillars. Access, ensuring services are available; quality, guaranteeing effective care; and equity, ensuring fair and just distribution of health resources to all. Indeed, countries around the world adopt a variety of distinct paths and models to achieve this overarching goal of universal healthcare. Each approach is tailored to their unique societal, economic, and political contexts. The United Kingdom's National Health Service, widely known as the NHS, stands as a prime example of a beverage model system. It is primarily funded through general taxation, ensuring that healthcare services are provided free at the point of use for all residents, from routine checkups to complex surgeries. Canada, on the other hand, operates under a single-payer system, often referred to as the National Health Insurance Model. Here, the government acts as the primary insurer, ensuring universal access to medically necessary services for all its citizens, funded through taxes. Japan utilizes a social health insurance model, a variation of the Bismarck model, where both employers and citizens share contributions to a mandatory health insurance fund. This system provides comprehensive coverage, allowing individuals to choose their providers while maintaining universal access. A fundamental and often debated question in the implementation of universal healthcare systems is always, who ultimately bears the financial responsibility? This question drives many policy decisions and public discussions. Universal healthcare systems are typically financed through a combination of mechanisms, primarily through taxation, through mandatory social insurance contributions from individuals and employers, or often through a pragmatic mix of both approaches, balancing public and private funding. Despite the varied funding models and administrative structures, the ultimate goal remains consistently the same across all universal healthcare systems: to foster collective investment in health for the collective well-being of the entire population, ensuring a healthier society for everyone. Some of the most effective and efficient healthcare systems globally are those that strategically integrate large, specialized hospitals with accessible, local community clinics. This integration creates a seamless continuum of care, from advanced treatments to preventative services, ensuring patients receive the right care in the right setting. Technology is rapidly transforming and expanding access to healthcare in unprecedented ways. This ranges from sophisticated AI-driven diagnostics that enhance accuracy and speed to user-friendly mobile health applications that instantly connect millions of individuals to medical professionals for consultations and advice, bridging geographical gaps and improving convenience. Of course, significant challenges persist on the path to achieving truly universal healthcare. These include persistent funding gaps, critical workforce shortages in medical professions, and deep-seated inequities in access and outcomes that continue to affect vulnerable populations. However, valuable lessons gleaned from successful implementations around the world clearly demonstrate what truly works. Unwavering political commitment from governments, active and meaningful community engagement in health initiatives, and the establishment of sustainable financing mechanisms that ensure long-term viability and resilience of the healthcare system. Looking ahead, by the year 2030, the United Nations has set an ambitious and crucial goal: to achieve universal health coverage as a cornerstone of its Sustainable Development Goals. This vision underscores a global commitment to health as a human right. The future of universal healthcare profoundly depends on continuous innovation in medical science and delivery, unwavering inclusion of all populations, and a shared, fundamental belief that no individual, regardless of their circumstances, should ever be left behind when it comes to their health. Ultimately, universal healthcare extends far beyond mere medicine and treatment. It is fundamentally about upholding human dignity, ensuring equitable access to life-saving services, and delivering social justice for every member of society. It is a reflection of a society's values. Our collective aspiration is clear: health for all. This means accessible healthcare everywhere, for everyone, always. It is a vision of a world where health is truly a universal right, not a privilege.
In the operating room, the human body presents itself as a great equalizer. Beneath the skin, the same intricate network of arteries, nerves, and organs performs its quiet, miraculous work in each of us. Yet, outside those sterile walls, the world intervenes. The health of a person, their very chance at a long and well-lived life, is profoundly shaped by forces far beyond their control. The neighborhood they are born into, the money their family has, the social status they hold. This is the great unfairness at the heart of modern medicine. We have developed astounding capabilities to mend the sick, but we have failed, in so many places, to deliver that capability to everyone who needs it. This is not a technical problem. It is a moral one. This essay is a tour. It is a journey through the ideas and systems that nations have built to confront this unfairness. We will not seek a single perfect answer, for none exists. Instead, we will look at different models of healthcare, not as abstract theories, but as living, breathing entities. We will travel from the bustling hospitals of the United Kingdom to the remote villages of Rwanda, seeing what succeeds and what falters. The goal is to understand the common design principles that allow a system to become not just universal, but truly inclusive. Let us begin with a clear definition. At its core, universal health coverage is a simple proposition. It holds that all people should have access to the health services they need, when and where they need them, without suffering financial hardship. The term inclusive universal healthcare can sound complex, a piece of jargon from a policy report, but the idea is deeply simple. It means that every single person should have access to good quality care when they need it, without the threat of financial ruin. It means the system is designed with intention to reach the marginalized, the poor, the rural, the socially excluded. It is about more than just opening clinic doors. It is about actively dismantling the barriers that keep people from walking through them. It is about building a system that sees everyone and leaves no one behind. This is the promise we will explore. The word inclusive adds a crucial layer to this foundation. A system can claim to be universal on paper, but in practice, it may fail to reach everyone. Inclusion demands that we pay special attention to equity. Equity is not the same as equality. Equality means giving everyone the same thing. Equity means giving people what they need to have the same opportunity. An inclusive model recognizes that some people start with disadvantages. Someone living in a remote mountain village, a person from a marginalized ethnic group, an individual working in the informal economy faces higher hurdles to getting care. An inclusive system actively works to lower those hurdles for them. Consider the practical meaning of this. It means designing primary care clinics to be physically accessible to the poorest communities. It means designing primary care clinics to be financially accessible to the poorest communities. It means training and deploying community health workers who can travel to the homes of those unable to travel themselves. Imagine a system where healthcare is treated like a public library or the fire department. It is a service provided by the government, available to every citizen, and funded by everyone through their taxes. This, in essence, is the Beveridge model, named after the British economist William Beveridge. He designed the blueprint for the United Kingdom's National Health Service. The government not only finances care, but also owns and operates many hospitals and clinics. Doctors may be public employees. Care should be free at the point of service and distributed according to need, not ability to pay. Centralizing funding and administration lets government exert strong control over total health spending, making it one of the more cost-effective models in the developed world. However, this model faces challenges. The most commonly cited problem is waiting times. High demand for a free service can outstrip available specialists and surgical slots, creating long queues for non-urgent procedures. To succeed, the Beveridge model needs sustained public and political commitment. This is the Bismarck model, named for Otto von Bismarck, who pioneered the world's first universal health program. In this system, healthcare is financed jointly by employers and employees through mandatory payroll deductions. These contributions flow into non-profit sickness funds, non-governmental sickness funds. These funds pay for care delivered by public hospitals, private hospitals, and doctors. It is a multi-payer system tightly regulated by the government to ensure universal coverage and quality standards. Germany, France, Belgium, Japan. In Germany, nearly everyone is covered by one of hundreds of sickness funds. The funds compete for members, but the basic benefits package is mandated by law. There is a third path, one that combines elements from both the Beveridge and Bismarck models. This is the National Health Insurance model. The government acts as the single payer for essential medical services. Providers are largely private. The hospitals, clinics, doctors, or a mix of public and private. All citizens pay into the government-run insurance program, typically through taxes or a dedicated premium. That single pool of money pays the providers for care. Canada is the most famous example. Provinces and territories administer their own public insurance plans. Residents get a health card and can visit the doctor or hospital of their choice without a bill for covered services. The government's role as sole payer lets it negotiate lower prices for drugs and procedures. Taiwan, South Korea also use successful NHI variations. The strongest benefits are administrative simplicity and cost control. One payment agency and one set of rules reduces overhead and paperwork. But it's not a panacea. A key challenge is deciding what is medically necessary, often excluding dental, vision, and outpatient drugs. Many people then rely on private supplemental insurance or pay out of pocket. That can create a two-tiered system and coverage gaps. To be inclusive, policymakers must make the essential benefits package comprehensive, especially for low-income populations. NHI shows universal coverage and efficiency are possible by separating financing from delivery. Beyond the grand architecture of national systems, some of the most powerful work in healthcare happens at the ground level. These systems are built not around large centralized hospitals, but around a dense network of local clinics, nurses, community health workers. The focus is on prevention, basic treatment, and building trust, one household at a time. Rwanda rebuilt its health system from the community up, training tens of thousands of CHWs to treat common illnesses, monitor pregnancies, ensure vaccination, and insurance enrollment. This approach, grounded in data and performance, slashed child and maternal mortality. Brazil's family health strategy embeds teams into neighborhoods, managing chronic disease and promoting health through proactive, sustained engagement. Even with a strong network of clinics, some people remain out of reach. To achieve true inclusion, a health system must find ways to bridge these final miles. Two powerful tools have emerged to meet this challenge: mobile clinics, telehealth. A van can be outfitted with basic diagnostics, essential medicines, and a small clinical team. In places like the Amazon, boat clinics bring care to riverside communities. Telehealth collapses distance. CHWs capture diagnostics and transmit to specialists far away. During COVID-19, telehealth's potential for access, efficiency, and safety became clear. These solutions require vehicles, fuel, maintenance, reliable supply chains, electricity, internet, digital literacy, and strong data privacy rules. For a system committed to leaving no one behind, these are not luxuries. They are necessities. Designing on paper is one thing, building in reality is another. Perhaps the most universal challenge is money. Securing stable, adequate, predictable financing requires leaders who see health as an investment in human capital. Workforce shortages, nurses, midwives, primary care doctors, are widespread, and staff cluster in cities, leaving rural areas underserved. Solutions include training more people and creating incentives, better pay, housing, professional support. Fragmented financing and eligibility rules create gaps and raise costs. Greater integration, through single-payer or strong regulation, improves equity and efficiency. Corruption and poor service erode trust. People avoid care even if it's free. Good governance and accountability are bedrock requirements. The great lesson is not perfection, but progress.
Section 1. The promise of universal healthcare. Universal healthcare is a simple yet profound idea. It means that all people, regardless of their station in life, can get the health services they need, when and where they need them, without suffering financial hardship. It is not a single rigid plan that fits all nations, but rather a guiding principle, a destination that countries can reach through many different paths. The core of this promise is about fairness, ensuring that access to a doctor or a life-saving medicine is not determined by the thickness of one's wallet. It is about building a society where illness does not automatically lead to bankruptcy, and where a child's future is not compromised by a parent's inability to afford a clinic visit. It is a commitment to the fundamental value of human health. Section 2. Why universal healthcare matters for everyone. Health is a resource that extends far beyond hospitals or doctors' offices. It is the invisible engine that powers our societies. When individuals are healthy, they are better able to work, contribute to the economy, pursue an education, participate in family and community life. Good health is the foundation for productive, joyful lives. When people have reliable access to medical care, small issues are less likely to escalate into catastrophic emergencies. Early diagnosis and consistent treatment prevent severe complications and long-term costs. Diabetes, high blood pressure. Furthermore, a healthy population is more resilient. Public health management, vaccination programs, is easier within a universal system. Containment of infectious diseases is more achievable with universal access. When everyone can access care, it's easier to track and stop the spread of illnesses. The health of one person is linked to the health of the community. Universal care also impacts the financial well-being of families. It provides a safety net, reducing anxiety about financial ruin from illness. Section 3. The Beveridge Model. Government as Guardian. The first model we will explore is named after its architect, William Beveridge. He designed the system for the United Kingdom after World War II. In the Beveridge model, healthcare is provided by the government, and it's financed directly through tax revenue. That means hospitals are often owned by the state, and the doctors who work there are, in essence, government employees. The guiding principle is that healthcare is a public service, like the fire department or the public library, available to all citizens regardless of their ability to pay. Care is typically free at the point of service, eliminating the exchange of money between patient and provider for most essential treatments. The United Kingdom's National Health Service, the NHS, is the classic example. The operational mechanics of the Beveridge model are centralized. The government acts as the single payer. It collects funds from general taxation and allocates them across the healthcare system through national budgets. Section 4. The Bismarck Model. Solidarity through insurance. The second major framework is the Bismarck Model, named for the Prussian Chancellor Otto von Bismarck, who introduced the world's first universal healthcare system in 19th century Germany. This model uses an insurance system, typically financed jointly by employers and employees through payroll deductions. Unlike the Beveridge model, where government directly provides care, the Bismarck system relies on a network of private hospitals and doctors. However, it is not a free market free-for-all. The insurance plans, known as sickness funds, are tightly regulated by the government to ensure comprehensive benefits and coverage regardless of pre-existing conditions. Germany is the quintessential example. The system operates on social solidarity. Both workers and their employers contribute a percentage of salary to a non-profit sickness fund of their choice. The third approach, the national health insurance model, represents a clever fusion Beveridge Bismarck. In this model, the government acts as the single payer, but delivery of care remains largely in private hands. People pay into a government-run insurance program typically through taxes or a dedicated premium. That public fund then pays private practice doctors and privately owned hospitals. The government does not own the hospitals or employ the doctors, but it holds the purse strings. Canada is the most prominent example of a country using the NHI model. When a patient in Canada visits a family doctor or goes to a hospital, they present their health card, not a credit card. The medical provider then bills the provincial insurance program directly according to a pre-negotiated fee schedule. Section 6. The out-of-pocket model, a system of last resort. The fourth and final model is the out-of-pocket model. This is the most basic and inequitable form of healthcare financing. It is less a structured system and more the absence of one. Individuals pay for medical care directly at the time of service with their own money. No widespread public funding or organized insurance pools, risk and shares costs. Common in rural Africa. Common in rural South Asia. Common in rural South America. Also common in low-income countries lacking resources or infrastructure. It exists where other systems have failed or aren't built. The mechanics are brutally simple. If you are sick, you must find a way to pay the doctor or pay the clinic. If you have the money, you can often get immediate care. If you don't have money, you may forgo treatment. Section 7. Blending the models, the reality of mixed systems. While the four models provide a useful framework for understanding healthcare, the reality on the ground is that very few countries adhere strictly to a single pure system. The vast majority of nations, including the most developed ones, operate mixed systems that borrow and blend elements from two or more of these foundational archetypes. This hybridization is not a sign of confusion, but rather a pragmatic response to the unique historical, cultural, and economic circumstances of each country. A nation might use a Beveridge-style public hospital system for the general population, while also allowing a robust Bismarck-style private insurance market for those who want faster access or additional amenities. France, for example, has a Bismarck-style social insurance system, but also significant government regulation and financing that gives it NHI-like features. For instance, a country with a tax-funded Beveridge system might introduce market-style incentives to reduce wait times, or allow patients to top up their public coverage with private insurance for services like dental care. Even the United States, which is unique among wealthy nations for not having universal coverage, has a deeply fragmented and mixed system. It employs elements of all four models simultaneously. This patchwork demonstrates how different models can coexist, albeit with significant challenges in coordination, cost, and equity. The lesson from these mixed systems is that there is no one-size-fits-all solution. Section 8. Common challenges and shared solutions. Regardless of the specific model a country adopts, all healthcare systems grapple with a set of universal and persistent challenges. The most prominent of these is financing and cost control. Every system needs a sustainable source of money: taxes, insurance premiums, direct fees. As populations age, expensive new medical technologies become available. The pressure on these financial resources intensifies everywhere. Successful systems are those that implement smart mechanisms for controlling costs, negotiating drug prices, setting clear budgets for hospitals, promoting preventative care to reduce the need for costly treatments, reducing administrative waste. Without vigilant cost management, even the best designed system can become financially unsustainable. Section 9. The path forward, choosing and building a system. There is no single perfect healthcare model that can be lifted from one country and dropped into another. The best path for any nation is one that is carefully tailored to its unique size, wealth, political culture, social values. A small, homogeneous country might find a centrally managed, Beveridge-style system to be highly efficient. A large, diverse, federalized nation may be better served by a more decentralized Bismarck or NHI model that allows for regional variation. The journey toward universal healthcare is not about finding a perfect blueprint, but about embarking on a thoughtful process of building and refining a system that works for its people. The first step on this path is to start with the basics. Rather than trying to build a comprehensive system all at once, countries can begin by guaranteeing a core package of essential, high-impact services for everyone. Prioritize primary and preventative care, local clinics, family doctors, vaccinations, maternal and child health. Make that basic package truly universal, with financial protections so the poorest and most vulnerable are covered from day one. Universal healthcare is a goal all countries can reach.
Everyone said you can't build a $200 billion empire on peace. Someone just did it anyway. While traditional development approaches struggle to deliver real change, Dr. Rashid Osman and World Peace Development Holdings have created something entirely different. They call it the Peaceism ecosystem, and it's turning everything we know about mega-scale development upside down. In Laos, they've just signed the largest foreign investment agreement in the country's history. Over $200 billion dedicated to transforming an entire nation's economy. But here's what makes this revolutionary. Instead of extracting resources, they're building integrated systems. Renewable energy, healthcare, education, industrial zones, all connected through what they call peace-driven development. The Lao Prime Minister called it transformative. International observers say it could become the model for sustainable growth in emerging economies. This isn't just about one country, it's about proving that peace, prosperity, and massive infrastructure can work together at unprecedented scale. World Peace Development Holdings builds mega-scale, peace-driven ecosystems with governments and private partners. The approach aligns infrastructure, industry, and social services to create jobs and resilience. At the center is people access to work, food, healthcare, education, housing, justice, and safety. Peace isn't abstract, it's dignity, protection, and equal opportunity. Join the Peaceism ecosystem. Learn, partner, and co-build the blueprint for sustainable prosperity. The Peaceism ecosystem is an operating system for national development. It coordinates governments, private partners, and communities in one integrated frame. Employment. Large-scale jobs and skills pipelines power long-term growth. Food. Regenerative agriculture and smart logistics for secure supply. Healthcare. Universal access and preventive care systems. Education. Lifelong upskilling for an adaptive workforce. Housing. Affordable, resilient, community-centric design. Justice. Transparent governance and rights protections. Safety, conflict resolution, disaster readiness, and cybersecurity. Peacecoin is the digital rail for transparent value distribution. It's not an investment contract. Coins are allocated based on human existence and community effort. Assets and decisions are recorded for auditability and public trust. A trustee model guides decisions with clear accountability. Community voice shapes priorities and surfaces local solutions. Design is community-centric solutions built with, not for, people. Capital grows alongside forests, skills, and incomes, not at their expense. Economic security links healthcare, education, income, shelter, food, and connection. A free global series activates collaboration from jobs and food to justice and resilience. The narrative is peace-first unity of humankind, dignity without borders, because all mankind is from one family. Opportunity must be universal. Stakeholders call the Laos Partnership a transformative step for long-term growth. Observers say it could model diversified, climate-ready development. This is implementation, not optics projects, delivering measurable change. Leaders and builders join, sponsor, speak, and co-implement the next Peaceism corridors. Next, how projects sequence to create lasting jobs, resilient cities, and shared prosperity. Phase 1 strengthens energy and logistics. Phase 2 scales industry and housing. Phase 3 expands social services. Reliable power unlocks factories, hospitals, and classrooms. Renewables lower costs and build energy independence. Freight corridors and smart customs accelerate exports and reduce waste. Mobility connects workers to opportunities and markets to producers. Industrial parks anchor jobs. SME clusters localize value chains. Entrepreneur programs turn talent into enterprises. Healthcare capacity improves well-being and worker productivity. Education expands human capital and future skills. Affordable, climate-ready neighborhoods reduce displacement risk. Public safety and social connection strengthen peace. E-services cut friction and corruption, increasing trust. Justice systems emphasize fairness and reintegration. A new job raises an entire household. Digital tools stabilize income and reduce waste. Connectivity multiplies value across sectors. Peace thrives where everyone belongs. Basic needs are engineered into the plan.
Thanks to the Peace ecosystem, I found support and community, especially in healthcare. It's a game changer.
Blockchain opened doors to jobs and resources I never imagined. It's empowering.
Visit the Expo series, Partner on Corridors. Let's turn peace into prosperity. We build for those who come after us. Clean power fuels opportunity. Care for all protects dignity. Skills for tomorrow unlock prosperity. Peace is measurable when lives improve transparently and at scale. Leaders, innovators, and communities, your seat at the table is ready. Equity by design, not by chance. Employment, food, healthcare, housing, education, justice, safety. Humanity first. Love, peace, joy. Unity without prejudice or borders. From river valleys to smart cities, the future is being built. World Peace Development Holdings, building a sustainable future through the Peaceism ecosystem. Subscribe, share, and join the mission. Peace is a plan and a platform. Let's build it together.
Imagine a world where healthcare proactively maintains wellness, preventing illness before it even begins. This isn't a distant dream, but a tangible reality we're building through preventive care ecosystems. Many of the illnesses that burden our healthcare systems and impact countless lives are, in fact, preventable. We're talking about a fundamental shift, moving beyond the emergency room and into the heart of our communities. So, what exactly defines a preventive care ecosystem? It's a dynamic, interconnected network of services designed to foster health and well-being within a community. At its core, this ecosystem integrates primary care, mental health support, and various community services,
all working in harmony. It's a holistic approach, recognizing that health is influenced by many factors beyond just medical treatment. This comprehensive model is built upon 5 essential pillars. First, integrated primary care, ensuring accessible and coordinated medical services for everyone. Second, mental health integration, recognizing the critical link between mental and physical well-being. Third, community engagement, empowering individuals and local groups to take an active role in their health. Fourth, data and digital health, leveraging technology to gather insights and deliver personalized care. And finally, policy alignment, creating supportive regulations and frameworks that enable these ecosystems to thrive. Why does this integrated approach matter so profoundly? Because a staggering number of chronic diseases, from heart disease to diabetes, are largely preventable. Consider the remarkable success of Finland's North Karelia Project, a pioneering initiative from the 1970s. Instead of solely focusing on building more hospitals, they partnered directly with the community. This collaborative effort, emphasizing lifestyle changes and public health campaigns, led to an astonishing 80% drop in cardiovascular disease deaths in the region. It's a powerful testament to community-driven prevention. The North Karelia Project exemplifies how empowering communities and integrating services can yield profound, life-saving results. It's a blueprint for what's possible when we prioritize prevention. Today, technology is further revolutionizing our ability to prevent illness. Wearable devices, for instance, continuously monitor our vital signs, offering real-time insights into our health. Artificial intelligence analyzes vast amounts of health data, identifying patterns and predicting potential health risks long before symptoms appear. This proactive intelligence is a game changer. Telehealth platforms bridge geographical gaps, providing access to medical consultations and mental health support from the comfort of our homes. This accessibility is crucial for underserved populations. The future of healthcare is holistic and person-centered, where data isn't just collected, but actively used to prevent illness. Imagine a system that anticipates your needs, guiding you towards optimal health. This future envisions a healthcare journey where prevention is paramount, empowering individuals with the knowledge and tools to maintain their well-being throughout their lives. Ultimately, health is not solely built within the walls of hospitals, but cultivated within our communities. It's a collective responsibility and a shared journey. By uniting medical care, mental health services, and robust community systems, we can create a healthier, more resilient world for everyone. This is the profound promise of preventive care ecosystems, a future where wellness is a community-wide endeavor, ensuring a better quality of life for all. Remember, prevention is not merely an act, it is an entire ecosystem.
Many people think mental health is separate from physical health. They believe the mind and the body are two different things. This is a common myth. It makes people think you only see a special doctor for your mind. They might feel ashamed to ask for help. This idea can stop people from getting the care they need. It creates a wall between different kinds of doctors. This wall makes it hard for people to feel completely well. Feeling sad or worried is a part of our total health. It is not something to hide or feel bad about. The truth is very different. Our minds and our bodies are deeply connected. Mental health is a key part of our overall health. Let's start with a common myth. Some people believe that only psychiatrists in special hospitals can treat mental health problems. They think you must be very sick to need this kind of help. This idea makes mental health care seem scary and far away. It suggests that your family doctor cannot help you with feelings of stress or sadness. This belief is not true. It creates a barrier that stops many people from even asking for support. It makes mental health seem like a secret, separate world that is hard to enter. This way of thinking is old and needs to change for people to get better. The fact is, mental health care can happen in many familiar places. Integrated mental health care is when mental health services are part of your regular health care. Your family doctor's office is a great example. You can talk about your feelings in the same place you go for a cough or a checkup. This makes it much easier to get help. It feels more normal and less scary. The goal is to treat the whole person, both mind and body, together. This approach recognizes that our emotional well-being is just as important as our physical well-being and that they are connected. This simple idea is very powerful. When mental health support is in a primary care clinic, it becomes more accessible. People trust their family doctors. They already have a relationship with them. This trust makes it easier to talk about difficult topics like anxiety or depression. The doctor can then connect the patient with a mental health expert who works right there in the clinic or nearby. This teamwork ensures that the patient gets the right kind of care quickly. It removes the long waits and difficult journeys to see a specialist in another part of town. So, what does this look like for a patient? It means you can go to one place for most of your health needs. Your family doctor, a nurse, a mental health counselor, all work together as your team. They talk to each other about your health. They create a single plan that supports both your physical and emotional needs. It is a common-sense approach that puts the patient first, making care simple, coordinated, and effective for everyone in the community. There is a myth that a family doctor must handle everything alone, or they must send a patient far away to a specialist for any mental health concern. This myth suggests there are only two options. The family doctor does it all, or the specialist does it all. This puts a lot of pressure on the family doctor. It also creates a long and difficult path for the patient. This old view does not use the skills of a full healthcare team. It makes care inefficient and can leave patients waiting for help. The fact is, a team-based approach works much better. This is called the collaborative care model. In this model, the primary care team works closely with mental health specialists. The specialists might not be in the same room, but they are part of the team. They help guide the family doctor. They review cases and give expert advice. This way, the family doctor feels more confident. They can provide great mental health care with the support of an expert. Let's look at an example. Maria went to her family doctor because she was feeling sad all the time and had no energy. Her doctor, Dr. Chen, recognized she might have depression. In the collaborative care model, Dr. Chen did not work alone. He worked with a care manager named David. David called Maria every week to see how she was doing. He taught her ways to manage her mood. David also talked with a psychiatrist, Dr. Evans, every week. Dr. Evans gave advice on Maria's treatment plan. Dr. Chen, David, and Dr. Evans worked together to help Maria feel better. This model is powerful because it uses everyone's skills wisely. The family doctor knows the patient's full health history. The care manager provides regular support and connection. The psychiatrist provides expert knowledge for more complex cases. They do not all need to be in the same building. They can connect through phone calls or secure messages. This teamwork brings high-quality mental health care into the familiar setting of a primary care clinic. A common myth is that you must go to a separate, special building for mental health care. People imagine a clinic that only treats mental illness, often far from their home. This idea reinforces stigma. It makes it seem like mental health is something to be hidden. If you are seen going into that building, people might judge you. This fear of judgment can be a huge barrier. It can stop someone from seeking help, even when they are struggling a lot. The separation of services makes it harder to take that first step. The reality, mental health services and physical health services can be in the same building. This is the co-location model. Mental health professional, counselor, social worker, office in the same clinic as your family doctor. Go for a checkup, see a counselor in the next room. No need to travel to a different location. As easy as getting a blood test. Normalizes caring for emotional well-being. Example: Sam. Sam came for frequent headaches. Doctor speaks with Sam and notices stress about a new job. The doctor said, "We have a wonderful counselor here named Maria. She is great at helping people manage stress. Her office is just down the hall. Would you like me to introduce you?" This is called a warm handoff. It makes the connection easy and comfortable for the patient. There is a myth that doctors' offices are the only places to get help. Many people believe that healthcare only happens inside the walls of a clinic or a hospital. This view is very limited. It ignores all the wonderful resources that exist in our communities. It makes people think that if they cannot get to a doctor, they cannot get any help at all. This is not true. Our communities are full of people and organizations that can support our well-being. We just need to build bridges to connect them with the healthcare system. Let's consider an example. An older woman, Mrs. Devi, told her nurse that she felt very lonely since her husband passed away. The nurse knew that Mrs. Devi's health was being affected by her loneliness. Instead of just giving medicine, the nurse used the community-linked model. The clinic had a partnership with a local senior center. The nurse gave Mrs. Devi a flyer for a weekly social club at the center. A community health worker from the clinic even called the center with Mrs. Devi to help her sign up. This simple connection helped Mrs. Devi find new friends and feel less isolated. This model is so important because health is about more than just medical treatment. A person's environment and social life have a huge impact on their well-being. By linking with community resources, clinics can help address the root causes of health problems. A community health worker often plays a key role here. They act as a bridge between the clinic and the community. They understand the local culture and resources. They help patients navigate these systems and get the support they need to live healthier, happier lives. You know, it's that kind of connection that really makes a difference. There's a myth that if an idea is good, it will just happen on its own. People assume integrated care's effectiveness means it's easy to implement everywhere. That's a lovely thought, but not realistic. Real-world challenges slow down progress. Believing change is effortless can make us feel discouraged. It's more helpful to be honest about the barriers. By understanding them, we can create practical plans to overcome them one by one. The fact is, there are 3 main barriers to integrated care. Barrier 1, a shortage of workers. A practical solution is to train more types of people: nurses, social workers, community health workers. This is called task sharing. Barrier 2, funding. Often insurers pay separately. A solution is to change how we pay for care, create payment models that reward teamwork, like bundled payments. Barrier 3, stigma. Talk openly and make mental health part of every visit, from receptionist to doctor. Smart policies can help integrated care grow everywhere. Invest in training and update payment systems so clinics are paid for care managers and consults. Let us leave the old myths behind and build a future where mind and body care is seamless, so every person has the chance to be truly well. Mental health is a fundamental part of our overall health, and it is not separate from our physical well-being. When people experience challenges like depression, anxiety, other emotional difficulties, they need support that is simple to find and easy to access. For a majority of individuals, the first point of contact with the healthcare system is their family doctor, a local community clinic. This is precisely why we must bring mental health care into these familiar and trusted spaces. Integrated mental health care is a framework designed to do just that. It aims to weave mental health services directly into the fabric of primary care and community settings, creating a system that is whole, accessible, and continuous for every person who needs it. A significant portion of the global population living with mental health conditions receives no formal care. In many nations, the gap is staggering, with the vast majority of people never getting any form of treatment. Individuals may hesitate to seek help from a specialist for many reasons. They might not know where to turn for assistance, or they could be worried about the social stigma that is often attached to mental illness. Financial constraints. A lack of available services can also create insurmountable barriers. Placing mental health support within primary care settings helps to dismantle these obstacles, allowing people to receive help in an environment they already know and trust. This approach does more than just improve access. It fundamentally changes how we view and deliver health care. It encourages primary care clinicians to see the entire person, recognizing that emotional distress can profoundly impact physical health and vice versa. A patient with diabetes might also be struggling with depression, which can make it harder for them to manage their condition. By addressing both issues together, the healthcare team can provide more effective and comprehensive support. A wealth of evidence clearly demonstrates that integrated care models lead to better access to services, higher quality of care, and ultimately, improved health outcomes for patients. It closes the distance between mind and body, treating the person as a whole. The principle behind integration is simple but powerful. Meet people where they are. By removing the need for separate appointments at different locations with unfamiliar providers, we lower the practical and psychological hurdles to getting help. This is particularly important for people living in rural or underserved areas, where specialist mental health services may be scarce or non-existent. Integrated care brings the expertise closer to home, often using technology and team-based approaches to extend the reach of specialists. It transforms the primary care clinic from a place solely for physical ailments into a true health home, a place where all aspects of a person's well-being are acknowledged and cared for with dignity and respect. One of the most well-researched and effective models of integrated care is known as the collaborative care model. This approach is built around a dedicated team working together to support a patient's mental health needs within the primary care setting. The core team typically consists of 3 key players: the primary care clinician, a dedicated care manager, a consulting mental health specialist, such as a psychiatrist, a psychologist. The primary care clinician continues to be the main provider, but they are no longer working alone. They are supported by the other members of the team who bring specialized skills and focused attention to the patient's mental health journey. The care manager is the engine of the collaborative care model. This individual, often a nurse, a social worker, a trained counselor, works closely with patients who have been identified with a mental health need. They provide regular follow-up, often by phone. They monitor symptoms. They check on medication adherence. They offer brief behavioral therapies. The care manager acts as a vital link between the patient and the primary care clinician, ensuring that the treatment plan is being followed and adjusted as needed. This consistent and proactive engagement helps patients feel supported. It prevents them from falling through the cracks, which can easily happen in a busy traditional clinic setting. The mental health specialist provides essential expertise and guidance to the entire team. This specialist typically does not see every patient directly. Instead, they meet regularly with the care manager to review a caseload of patients. They provide recommendations on treatment plans. They suggest medication adjustments. They recommend strategies for engaging individuals who are not improving. This is often called a caseload-based consultation. By advising the care manager, the specialist can leverage their expertise across a much larger number of patients than they could ever see in individual appointments. They are available to see patients with more complex needs. But their primary role is to empower the primary care team to handle common mental health conditions effectively. The evidence supporting the collaborative care model is robust and extensive. Numerous randomized controlled trials, including many large-scale studies, have consistently shown that this model leads to significantly better outcomes for common conditions like depression, anxiety when compared to usual primary care. Patients in collaborative care programs are more likely to experience a reduction in their symptoms. They are more likely to adhere to their treatment plans. They report higher satisfaction with their care. Organizations like the American Psychiatric Association and the World Health Organization have recognized its effectiveness, recommending it as a best practice approach for integrating mental health services into primary care systems around the world. In many parts of the world, there are simply not enough specialist mental health professionals to meet the overwhelming need. This workforce gap is a major barrier to accessing care, especially in low and middle-income countries and in rural or remote regions of wealthier nations. The model of task shifting, also known as task sharing, offers a practical and powerful solution. The core idea is to train non-specialist health workers to deliver basic, evidence-based mental health interventions. These workers can include nurses, community health workers, lay counselors, and peers with lived experience. Break treatments into simpler components that can be taught without years of specialist training. For example, a lay counselor can deliver behavioral activation for depression, helping people re-engage in positive, rewarding activities. The goal is not to replace specialists, but to extend reach by building a larger community-level workforce. Crucially, task shifting does not mean task dumping. It must be built on training, supervision, and support. Workers receive focused initial training and regular specialist supervision, discussing cases, asking questions, and continuing to learn. Ongoing mentorship ensures high-quality care and supports workers in challenging roles. Compelling trials in India, Pakistan, and Zimbabwe show brief treatments by trained lay workers are effective. The WHO endorses this through its Mental Health Gap Action Program. This model is scalable and cost-effective, closing treatment gaps and bringing care to millions. The stepped care model uses resources efficiently, matching treatment to severity. Start with the least intensive, most accessible, and safest interventions likely to help. Patients are regularly monitored, and if they do not show significant improvement, they step up to a more intensive level of care. This avoids overtreating mild issues and undertreating severe conditions, making care patient-centered and resource-conscious. Steps typically progress in intensity. First, watchful waiting for very mild symptoms or access to high-quality self-help, books, websites, mobile applications. Next, guided self-help with brief, regular check-ins. Then, brief structured therapy by a trained counselor, or a medication consultation with the primary care clinician. Highest steps, long-term psychotherapy or specialist psychiatrist care. Stepped care depends on continuous monitoring. Simple questionnaires like PHQ-9 for depression and GED-7 for anxiety guide decisions and changes. Data ensures care remains active and responsive, not a static, one-size-fits-all prescription. Evidence is strong, outcomes comparable to immediate specialist care at much lower system cost, allowing more people to be served. The UK's NHS implemented this at scale through IAPT, expanding evidence-based treatments nationwide. Successfully launching an integrated care program requires careful planning and a step-by-step approach. Start small, pilot the model, scale up what works. First, assess local needs and resources, prevalence data, current services, and the perspectives of community members, patients, and providers. Choose a model that fits: collaborative care in well-resourced clinics, task shifting in rural areas with few specialists, based on funding, workforce capacity, and local needs. Train everyone in basics. Give care managers and lay counselors role-specific training. Establish ongoing specialist supervision. Set up workflows, simple screening, clear referral pathways, standardized outcome measures, and shared records when feasible. Start a pilot, collect data on what works, and expand to more clinics or communities. Overcoming the hurdles, common barriers, and practical solutions. There are global shortages of psychiatrists, psychologists, and clinical social workers. Expand capacity with task shifting and technology. Teleconsultation lets one specialist support many teams across wide areas. Reduce stigma with integrated services in familiar settings, public recovery stories, clinician communication training, and safe, welcoming environments. Address financing barriers with strong business cases, local pilot data, and advocacy for blended payment models and coordination codes. Start with shared measurement tools and scheduled team meetings. Build toward integrated digital systems over time. Real-world programs, from U.S. collaborative care to rural task shifting, improve recovery, reduce referrals, and boost clinician confidence. School-based models train teachers, add on-site counselors, and build resilience, improving attendance and culture.
O Lord of the world, creator of all that is, bless us with your infinite peace. May the Peaceism ecosystem guide every heart, every nation, and every creature toward harmony and unity. Let the Peaceism coin be a symbol of your divine abundance, spreading prosperity and balance across the earth. May all beings, seen and unseen, live in the light of your eternal peace, now and forever, O Lord of the world. bless every creature, great and small, on land, in water, and in the sky. May the Peaceism ecosystem protect them. And may the Peaceism coin ensure their well-being. Let humanity be their caretaker, guided by your wisdom. May all beings coexist in mutual respect and love, sharing this earth as one family under your divine guidance. O Lord of the world, healer of all wounds, bless every being with your restorative grace. May the Peaceism ecosystem bring balance to body, mind, and spirit. Let the Peaceism coin flow as a symbol of your abundance, ensuring no creature suffers from lack or pain. May all beings find comfort, healing, and renewal in your loving presence, O Lord of the world. Guide us with your infinite wisdom. May the Peaceism ecosystem illuminate our hearts and minds, teaching us to honor all life and cherish the earth. Let the Peaceism coin be a tool of your divine will, spreading prosperity and unity. May we walk the path of peace, spreading love and light wherever we go, under your eternal guidance. O Lord of the world, bless all beings in this life and the next. May the Peaceism ecosystem ensure their journey beyond this world is filled with light, love, and divine grace. Let the Peaceism coin symbolize your eternal abundance, ensuring no soul is lost or forgotten. May all beings find their way to everlasting peace and unity with you. O Lord of the world, bless this earth, our shared home. May the Peaceism ecosystem restore balance and vitality to every forest, river, and sky. Let the Peaceism coin flow as a symbol of your care, ensuring the well-being of all creatures. May humanity act as stewards of your creation, guided by your wisdom and love. O Lord of the world, awaken humanity to the truth of interconnectedness. May the Peaceism ecosystem teach us to see ourselves in every creature and every creature in ourselves. Let the Peaceism coin be a beacon of your divine will, replacing greed, violence, and ignorance with generosity, compassion, and wisdom. May we rise as one global family, united in your peace, O Lord of the world. We give thanks for the gift of life and the beauty of creation. May the Peaceism ecosystem ensure abundance for all beings, and may the Peaceism coin flow as a symbol of your divine blessings. Let gratitude fill our hearts, and may we share our blessings with all who are in need. May no creature go without. Under your loving care, O Lord of the world, may suffering cease in every corner of the universe. May the Peaceism ecosystem bring comfort to every heart, and may the Peaceism coin ensure prosperity for all. Let kindness and compassion guide every action, and may all beings find solace in your eternal love. May peace reign in every heart, now and forever, O Lord of the world. Celebrate the diversity of life and unite us in our shared humanity. May the Peaceism ecosystem honor every culture, species, and individual, and may the Peaceism coin flow as a symbol of your divine unity. Let differences be a source of strength, not division. May we all contribute to the symphony of peace under your guidance. O Lord of the world, may your peace reign in every heart, in every home, and in every land. May the Peaceism ecosystem guide us, and may the Peaceism coin flow as a symbol of your divine blessings. May all creatures now and forever live in harmony, joy, and love under your eternal care. So be it, with gratitude and...
Hey everyone! Today I'm thrilled to introduce a groundbreaking initiative, the Peaceism ecosystem. Launched by World Peace Development Holdings Limited, this innovative project is set to transform how we address humanity's most essential needs. Peaceism is all about building a decentralized and inclusive platform. It focuses on 7 key pillars: jobs, food, healthcare, housing, education, justice, and safety. Imagine a world where every person, regardless of their background, nationality, or creed, has access to these basic needs. Now, you might be wondering, how does this work? Well, the Peaceism ecosystem operates through 2 foundational tokens, Leah Coin and Peaceism Coin. These coins are already live on the blockchain, providing a decentralized framework to implement this ecosystem. This ensures that equality, inclusivity, and justice are not just ideals, but realities. The heart of Peaceism lies in its holistic approach. Employment opportunities ensure livelihoods, access to food supports communities in need, universal healthcare prioritizes well-being, housing solutions promote equitable living, education fosters knowledge, justice and welfare uphold fairness, and safety measures ensure secure environments. These 7 pillars create a sustainable framework for global prosperity, but that's not all. Peaceism introduces a new economic model centered on decentralization and collaboration. With decentralized governance, every voice is heard. Inclusive tokenomics allow everyone to participate. And fair resource distribution means that resources are allocated without bias. It's a system where humanity is the only criterion for access. This model is redefining wealth and resource distribution. Out of a total supply of 10 quadrillion coins, each living individual is allocated 1 million tokens. It's an innovative approach that ensures wealth is shared fairly across the global population. Peaceism is not just a concept, it's a platform for real-world action. Projects under this initiative aim to benefit communities worldwide. From community development and renewable energy projects to educational initiatives, each project brings significant and lasting change to underserved communities. And here's the best part. The Peaceism ecosystem invites participation from everyone. Governments, public agencies, financial institutions, enterprises, educational organizations, charitable foundations, NGOs, everyone is welcome to join. Together we can create a better, more equitable world. World Peace Development Holdings Limited extends an open invitation to individuals, organizations and communities to join this movement. As Rashid Osman, the founder, says, this is not just a platform, but a global movement to redefine prosperity and equality. So are you ready to be part of this revolution? Let's build a future where humanity's most basic needs are met with dignity and fairness. Join the Peaceism ecosystem today. Thanks for watching.